Hello, I'm Amy Lou Rettig from the Duke Clinical Research Institute, and I serve as a Mission Lifeline volunteer. I'm here today with two colleagues to discuss a trial that was presented today by Dr. Matthew Sherwood in Late Breaking Clinical Trials. It's a mouthful. It's called the Regional Systems of Care Demonstration Project, or fondly known as the Mission Lifeline STEMI Accelerator. I'm here with Dr. Granger and Dr. Jolles, my colleagues from Duke University. And Chris, would you discuss the trial?
Yeah, Mamie, so we know that coronary heart disease is the #1 cause of death and disability in the world, and acute myocardial infarction is the acute manifestation. And the most important way to prevent death from myocardial infarction is effective reperfusion for STEMI. And based on that, the American Heart Association, Alice Jacobs really began this, established Mission Lifeline, which has been designed to improve timely and appropriate reperfusion for ST elevation MI by working on systems of care. And it's been extremely effective, but it has focused mainly on PCI centers and the surrounding non-PCI centers and EMS systems. So what we've done in this project then is to say, can we go to entire regions and establish regional approaches to improving STEMI care by coordinating emergency medical services and hospitals on the basis of an entire region.
And this was quite an ambitious effort, right?
It was really a very ambitious undertaking. So we ended up with 16 regions, with 484 hospitals, with 1,300 EMS agencies, and with 24,000 patients with STEMI. So it's really one of the largest undertakings ever in working on coordinating regional care for STEMI. And what we did is we went out and the first thing we did was go and make sure that people were collecting data using the Action Registry Get With The Guideline tool. And then the data was analyzed and presented in regional reports. This was critical so that each region, and these are big places like New York City and Atlanta and Houston, we're talking about big regions. And each region then would have each of the hospitals in an alpha-coded manner be able to compare themselves in a blinded way to all the other hospitals in the region, and then to focus on areas that they had opportunity for improvement.
And use best practices of the hospitals that performed well in order to...
And that was critical, that there were regular meetings to review data, to share best practices, to talk about how on a regional basis emergency medical services could have standard protocols and work with hospitals in a systematic way.
Jamie, could you share some of the results?
Sure. I just want to echo, it was a massive effort with hundreds of colleagues, cardiologists, emergency physicians, nurses, administrators, medics, a huge effort. And it's just an honor to talk about this project. Our main measure was looking at first medical contact to device time, as you described, with goals being 90 minutes for EMS presenting patients, 120 minutes for hospital transfers, and 90 minutes for people coming right to a cath lab hospital. What we found, there were about 11,000 patients coming in by EMS, about 6,000 walk-ins, and about 5,000 transfer patients. A particular measure we think is very important is this ED time. So for patients coming in by EMS, if they've pre-activated and they're coordinated, that ED time is very short, less than 30 minutes. And on the other hand, if it's not coordinated or the patient has a complication, the ED time gets much longer. So that metric alone, just looking at that, not as a primary endpoint, but to really understand the importance of this, we found a really huge difference with a 3.6% mortality if your ED time was less than 30 minutes, and almost 11% mortality if it's beyond 45 minutes. And adjusting for everything we could, cardiac arrest, shock, etc., this was still significant. So at least it's telling us this time and this coordination is very important. Our main findings, looking across all regions together, we saw 5% improvements in the number of patients meeting the guideline goals.
And these were the aggregate.
Aggregate, but there were, obviously it's an 18-month intervention. There's still a lot of organizing going on and implementation. Looking at our top 5 regions, we saw improvements up to 20% of patients that were now meeting guideline goals 18 months later than we started. Huge changes in care.
And in fact, Jamie, this really was a demonstration project, wasn't it? And so the fact that these major regions were able to improve by this substantial amount of 10 to 20% improved proportion of patients meeting guideline goals is really, we think, does demonstrate that it is possible on a regional basis to substantially improve coordination of care for acute cardiovascular emergencies and make a major improvement in public health.
It is. It's all about Heart Association, Mission Lifeline, all our colleagues taking care of the patients. This is what we're here for, and this has been an amazing effort.
And it's also true that, in fact, we did see numerical improvement in mortality, which is, of course, our ultimate goal. And in fact, that the hospitals that were involved in the STEMI Accelerator program had numerically a more impressive improvement in survival than those who were not involved.
Yes, and I'd just like to thank all of the people that were involved in the study, especially those on the front lines, the paramedics, the nurses in the emergency departments, and our great physician leaders, and most importantly, the American Heart Association staff in each region that really provided the neutral skeleton for these competitive systems to work together. Thank you.
Thank you very much.